Good morning. Welcome to Struggles of the Spirit. I'm your host, the Reverend Leland Udell. I'm delighted that you tuned in to the program again and that we are again sharing our minds and spirits today. We're looking at a subject that is, you might say, controversial, interesting, and puts responsibility on all of us. It's not an abstruse religious topic. Instead, it's about medical errors in medicine. This is still struggles of the spirit because it's not easy to deal with a possible error, either for the consumer or for the physician or the healthcare organization. It's difficult, and there's a real struggle of the spirit, particularly in trying to come together and to share the feeling that there may be an error going on. So to facilitate this subject, I have an expert here, Dr. Allan Ramsay. He's a physician at Colchester Family Practice. He's also a physician teacher, professor at the College of Medicine at the University of Vermont. So it's wonderful to have you here, Allan. I appreciate this was your idea. So many of the topics that I present here are my ideas to begin with anyway, but this was your idea, and so I salute you for being willing to talk about a medical error. And before I give you a chance to speak, I have decided with consultation with Dr. Ramsay to encourage you people, our viewers, to phone in whenever you would like during our conversation for the next hour. The number to phone in is 658-5165, and we invite you to do that at any time. And as soon as we know that you are there waiting for us to join with you, we'll open the line and we'll be conversing. So please phone in and share your thoughts with us, your experience with us. So Dr. Ramsay, it's great to have you here.
Well, thank you for that introduction, Reverend Udell, and I'm happy to be here again. This topic of errors in medicine indeed fits our theme of struggles of the spirit, and we'll find that out in more detail a little as we talk over the course of this hour. And like yourself, I would invite our viewers to call in over this number at any time during the hour with questions that they might have about our comments, about some of the statements that I make, and some of the issues that I review. To begin, let me say that this particular topic has been discussed in great detail since the publication of a document by the Institute of Medicine entitled "To Err is Human" in November of 1999. This was a document, a 300-page book, which for our viewers, don't go looking for it because it's not yet in hardcover publication. I've tried all of our local sources and I found that it's not yet available, but this book was presented to the public primarily through news and press releases and the Institute of Medicine, a book compiled by a committee of experts on the process and issues of how errors occur in the course of providing the best medical care we can provide to our consumers. So this book or report called To Err is Human, very appropriate title, began the discussion. The discussion to date has been focused on legal, economic, political, and even public health concerns. What you and I are going to talk about this morning is more about the doctors themselves, because that's who I represent, how they respond, how they feel.
And I would encourage you to focus in on the doctor and the patient relation.
The patient, right. So we're going to focus more individually on how someone on the front line feels about this new debate. It's an important one. It's brought to light an issue that all consumers and all physicians, I think, want to have addressed. But rest assured, it's difficult to talk about. In general, physicians and all medical care providers are focused in the greatest detail on reducing the risk of any type of mistake or error in the course of providing medical care. They are trained, and they're probably the most careful of the professionals that any of us would deal with because of their background and their training. They can cause, on the other hand, significant harm to people in the course of doing the best that they can do. And even the thought, even the concept, the perception of harming one of our patients, who we feel so strongly about, is painful. It violates the most hallowed principle of the Hippocratic Oath, and that is primum non nocere. First, do no harm. So the debate has begun. It's been focused around a report. Now, what is in that report that has made the debate come to life, end up on the front page of the New York Times the first week in December, the front page of the Burlington Free Press?
Physicians are really responding to this.
Well, they are responding because the report is so frank about what is occurring in medicine in the United States. The estimates are anywhere from 44 to 90,000 deaths a year related to errors in medicine. Those are estimates. They're based on reviews of information after the fact, which we know in science are not always the most accurate way to develop evidence. But those of us who practice medicine also know that it's a very complex task in that we are human. So errors are going to occur. Hence, to err is human. Now, why has it been so long that physicians, medicine in general, the systems that we work in, have not made a presentation like this in a report from a very prestigious part of the government called the Institute of Medicine? Doctors are taught to be infallible. They are taught that perfection is the only standard to which they will be held. If we study hard enough, if we work hard enough, if we work enough hours, if we think hard enough about each individual patient and their problems, if we consult the right physicians, errors won't occur. That's the way we're taught, that concept of perfection and infallibility. So if we do make an error, if there is an outcome in which we are unsure of whether or not the best thing was done for our patient, what happens? Immediately those feelings come about that I should have worked harder, I should have studied more, I should have consulted more often, I should have stayed there longer hours, and I'm guilty. It's not a matter of errors do occur because you're human and you need to develop systems to prevent them. It's all of a sudden we have a character flaw because we were human. That is the culture that physicians are trained upon right now. We have to change that culture with our patients. That is the first step. And having reports like this help to bring about a change in the culture.
But how, if you admit that physicians are human, how do you avoid getting physicians or hospital staff to the point where they shrug their shoulders and, oh, you win some, you lose some, you know?
Well, there have to be an enormous number of checks and balances in the system to accept your humanness. Now, we are not the only high-risk occupation. Medicine is not the only high-risk system. No. But we know in medicine, and the estimate is that we're about 10 years behind the airline industry, the nuclear power industry, the weapons production industries, in having the correct systems in place to make it more difficult for an error to occur in the hospital, in the clinic, by a physician, by a nurse practitioner, by a technician, a surgical OR nurse. we know that we are 10 years behind in having the correct systems in place compared to other high-risk industries. For example, the airline industry. In the year 1915, there were about 2,000 pilots in the United States. In 1918, the United States Mail Service started to shift over to an air mail delivery system. 1918. By 1920, 75% of the pilots who were flying for the United States mail system had been killed in accidents because they were required to fly to keep up this new mail delivery timing schedule. They were required to fly in conditions that were totally unsafe. So they were required to work in a system that was unsafe. This all occurred 72 years ago. So they unionized, and the first thing that the Airline Pilots Union did was say, we will not be required to fly according to our ground handlers or air traffic controller rules unless those air traffic controller go up and fly around that airport at the same time. So that's how they resolved the system issue in 1920. So the airline industry is very much ahead. 10 million takeoffs and landings a year minimum, 3 or 4 accidents. They are very ahead in developing the systems that need to be in place to reduce error management, to reduce the possibility that an error can occur in the light of a complex task.
So you're saying a system improvement could
Correct.
Avoid medical error? A
system improvement, it could. So you put systems in place that make it very difficult for an error to occur. Let's think about information or medication flow in the hospital. What are some of the systems that are coming into place now? It used to be that a doctor would write an order, which may or may not be fully legible. A nurse would take that order off of the chart, request a medication from the pharmacy. The pharmacy might send up a vial of this medication, which could be 10 times what the patient needed. Then the nurse would be responsible for reducing that to the correct dose and delivering it to the patient. Now, there are at least 6 steps there where errors could occur, which could be preventable. It has to be legible. It goes directly to the pharmacist. The pharmacist calculates the dose, correct dose, compares it to the ordered dose, draws it up, gets it back to the nurse. The nurse cross-checks it, delivers it to the patient after all of those checks have been occurred. Now, those are the things that are already going on. They are systems that are coming into place to reduce the risk of medication errors. It's estimated that among the hospital-based errors in this report, 50% of them had to do with medications. It's an area where systems can reduce that dramatically.
I was always impressed, having spent most of my life working as a chaplain in institutions, hospitals. A nurse taught me years ago that when you go to the patient's bed, well, I guess as you prepare the med, this is the old style, the med tray, you look at the bottle and then you put the pill in the little cup. And then you look at it again to make sure you really put the right one in, and then you do that again when you actually get to the patient's bedside. You don't have the bottle anymore, but you check the card. You like 3 checks before you actually give it to the patient. So
the first step, one of the steps to reassure all of our viewers, which again we're happy to have call-ins to 658-5165. The first step is to develop the kind of systems, information systems, tracking systems that reduce the likelihood of an error in the complex task of providing medical care. Every system, there's no perfect system in the airline industry, the nuclear power industry, or the weapons development. There are no perfect systems. Those other high-risk industries look at a mistake, an error, a bad outcome as a way to constantly improve the system. So they identify them quickly. We know that when there's an airline crash, there's a team from the National Airline Transportation Safety Board. There is an enormous investigation that goes on to find out, to detail every single event that led up to that.
May I make a comment about that, though? Or am I interrupting you with
No,
this?
go right ahead.
I think everyone knows if the seats faced the rear of the tail, if there were a crash, you would be much better able to survive the crash than the way they are currently placed now. But everyone knows that, but no one will change it. Why is that kind of fixed attitude in place? And doesn't I'm using that as an example for medicine.
Yeah, there are social issues and societal issues and as well, but in order to look at, to have systems in place that really function to reduce any chance of my patients being harmed, I have to be willing to recognize and divulge when a bad outcome has occurred, potentially because of some event that I was a part of, an error that I might have made. I have to be willing to do that. We started to talk a little bit about how doctors generally feel. They advocate for their patients. They're taught that the doctor-patient relationship is the most important thing, and that first doing no harm is the most hallowed principle. So it becomes very hard to talk about it, for doctors to talk about it when something goes wrong that they think they may be culpable for. If they don't talk about it and research why it happened, it's hard to have any system that is going to change that. So let me talk a little bit about why doctors don't talk about it. And it's the pain and anguish they feel. Some will say, oh, they're afraid of getting sued. They're afraid the lawyer's going to find out and sue them. I would argue that it's a deeper emotional issue than that. Because if you look at the studies of physicians who have had, let's just say, malpractice suits associated with a bad outcome, and the emotions that they go through, which include some denial first, I couldn't possibly have done that, enormous amounts of guilt, fear about losing their license, about losing their patients, about losing their credibility with their peers, anger, and then depression. And it's very consistent that this leads to significant depression in providers of healthcare because they've been, the way they've been taught, this perfectibility. So it's more than just the concern that they have that they're going to be sued. It's the concerns that's their own feelings and the powerful feelings they have for the person, for their patient, who they might even have felt they let down. In our society, the only compensatory mechanism we have is through litigation. Litigation, malpractice suits do not identify bad doctors. That has been shown over and over.
What do you mean by that, Alan?
In other words, let's say we want to be sure that we have the best physicians. We look at their training background, we put them through a credentialing process, a licensing process through the state. We expect that they have continuing medical education as part of their career. Okay, those are the things we do. There are still bad doctors. So how do you, even with those first 4 steps, how do you identify the bad doctors? The ones that are continuously making errors and hiding them. Malpractice litigation is probably not the best way to do that, because if you look at the people who are sued, they don't necessarily meet the criteria for being bad doctors. They're well trained, they're respected in their communities, they're licensed, they're credentialed, they're subspecialized, they work long hours. So to err is not necessarily equivalent to negligence or to being a bad doctor, just like to be sued is not necessarily a bad doctor. But in our society, the only way a person, most of our viewers have to be compensated for a bad medical outcome is through a malpractice suit. We don't have any type of system of compensation. We don't even have national health insurance. So we've still got anywhere from 5 to 10 million people in this country who do not have health insurance, much less any no-fault compensatory plan for when you are injured, which would change a lot of the systems, that a lot of the concerns that are now in place. It wouldn't change all of them, but it would change some of them. So doctors, trust me, go through a very emotional response when they feel that there has been harm, that there's been an error in the way they've practiced. It's well defined. That, to date, has been maybe one of the impediments to divulging something that could be corrected so it never happened again. My interest in this whole topic began 5 or 6 years ago when I started working with a tool called a problem knowledge coupler developed by Professor Lawrence Weed. The problem knowledge coupler is a way to gather an enormous amount of information about a person or a problem, link that information to the medical knowledge, and couple those two to come up with the most likely problems associated with a condition. In other words, it reduces my reliance on memory to reduce the risk that I am going to make a medical error. So we started using the problem knowledge couplers in the office, and I started to see the power of an information tool as part of this whole overall system. The next step was in my teaching responsibilities at the university. I'm the course director of a course called the Physician and Society, which is required for all the freshman medical students. So about 3 years ago, we developed a module or one session on errors in medicine to teach to all freshman medical students, where we had a panel of physicians that would come in and talk about their own experiences to medical students very early in their career. And that has been, one of the students all report, gee, this is a whole new area for us. We came here thinking about the perfectibility of the physician in the hospital and the highly technical medical care system, and you're telling us it's not perfect. What can we do? So they start out early in their career understanding that this culture of perfection is not going to sustain them through all of their humanity, which is what is important to their medical care. We're hoping to continue that part of the curriculum throughout the residency education program as well. So that's a long discussion about some of the feelings that physicians are evoked. And those feelings are important, but at the same time cannot interfere with the development of better systems. This report from the Institute of Medicine has started to change our thinking about these systems. So again, if our viewers are listening, this is a discussion about errors in medicine and struggles of the spirit, and we'd be happy to take calls on 658-5165.
Please call us right now if you would like to respond. You don't have to wait till any later moment in the program. Right now is perfectly fine. Having worked in hospitals most of my life, I do remember at a different hospital, not even in Vermont, there was an older physician who was an ENT, ear, nose, and throat surgeon, and the staff knew that he generally had bleeding problems with kids who had tonsils removed, and the staff generally felt it was because he should have laid down the scalpel because his sight wasn't as good, and he had a little tremor, but they weren't going to they all loved him. They weren't going to raise any issue with the medical staff or the medical board about him being removed from active surgery. And I don't know what eventually happened, but what do you do about those kinds of situations?
Right. Removal of physicians' privileges because of their competency, is a very difficult process. We have the State Medical Practice Board. We have wellness committees in all the hospitals in this state now, I believe, which can deal with this in a supportive way, rather than a punitive way. But that issue, whether it's an impaired physician or a physician with clear limits on competency, is complicated. But there are layers, starting with the credentialing process, the wellness committee evaluation, the State Medical Practice Board, and its ability to set limits on licensing procedures and stipulations. So, but that you raised a complicated issue. Not necessarily just this person may, even though they have certain divergences in how they practice, has been an established provider in the community for many years with a lot of respect. Let's talk a minute about other prevention issues too in this area, because you asked me, gee, isn't there some fear that we brought this up now and people are starting to realize how common it is, and the President of the United States has reported his own initiative. There is congressional action in the areas of identifying the reasons that errors occur in medical practice, and a target of at least a 50% reduction over the next 3 to 5 years through funding of congressional initiatives. So this has reached a political debate as well as a fundamental medical debate. So what do we have in place now in terms of prevention? We certainly have, in all medical centers and hospitals, conferences that expand knowledge, and we have continuing education requirements. We also have conferences that look specifically at outcomes. The classic one being the Surgical Morbidity and Mortality Conference, where a case is presented in front of all the surgeons, all the surgical residents, the surgical students, and the most senior expert reviewers are there to discuss the quality of care and to review where quality might have been improved or where areas of outcome were unexpected that could not be predicted. So the Morbidity and Mortality Conference has been a powerful tool for over 50 years in every hospital setting. We have incident reports at all levels of hospital care. Any employee at Fletcher Allen can put an incident report in, which has to be reviewed and tracked. We have adverse event reports, particularly around medication administration. We have a risk management program where unexpected outcomes, whether they related to errors or not, are reviewed at the level of risk management at the hospital, and not the least of which we have quality assurance programs, a hospital-wide quality assurance program, and each department has divisional and department-wide quality assurance programs, looking at anticipatory issues, things to do to improve quality. So those have been in place and are well established. Our expectations, part of our Joint Commission accreditation process, they have to be well-funded, well-supported, and understood by all medical providers. So that's what exists now.
It might help if you explain to the public the JCAH,
okay.
Because
the Joint Commission on Accreditation of Hospital Organizations, JCAHO, accredits all hospitals in the United States, all medical centers. It's a rigorous process in which an accreditation may be given for 1 to 3 years, so it's done on a regular interval. It takes a team of people to come into the hospital and look at all of the conditions of the hospital, all of the processes, all of the current systems in place, and all of the quality assurance programs. If you are not accredited by this organization, you are not entitled to receive Medicare funding for the care you provide. So you have to have accreditation. And
the residency programs are invalid for all the physicians who are training.
And all the residency programs have their own accreditation process through what's called the Graduate Medical Education Committee, and which has its own quality assurance, its own educational program. So at each level, there are systems in place. The question is, Are they adequate? And are they up to snuff compared to the other high-risk industries in this country? And we don't believe they are. We are 10 years behind. So what does the future potentially hold? We've already talked a little bit about systems. The Institute of Medicine in this report suggested that there are 4 additional steps that must be taken. And we can talk about those that are more and less controversial. The less controversial steps that will be taken as a consequence of this report is that a National Center for Patient Safety will be established. This will bring us closer to those other industries in a more quicker fashion. It will be funded by the Health and Human Service Agency, the Healthcare Policy and Research Branch. Congress is estimating that it'll spend over $30 million to establish a center. A second step is that the role of the consumer, that's all of us are consumers of healthcare, the professionals at all levels, including physicians, and the accreditation groups will be looked at with more detail, because this is not a change that will occur just from the top of the system. It's going to have fundamental changes are going to have to come about to improve patient safety from patients, from hospitals, from providers, from insurance companies. If the reason I make an error, if I don't recognize an abnormal lab test that comes back to me and act appropriately on it, because the amount of paperwork that I have to deal with is so enormous, or the amount of time that I have to spend with my patients is being so limited, then those are systems problems that have to be changed. The third one is building a culture of safety. That's the third step. Healthcare organizations have to create an environment where safety is preeminent, is tantamount, is the most important concern. Cutting my time down with my patients from 30 minutes to 20 minutes to 15 minutes to 10 minutes is not an environment that promotes enough communication to reduce the risk of a mistake. The last one, which I think has been most controversial in terms of these steps, is a mandatory reporting system versus a voluntary one.
What does that mean?
What that means is right now we have no regulations, laws, or rules that say that when something a bad outcome, let's say an error or a mistake or a slip occurs, that it has to be reported to either the hospital or to the medical practice board or to your credentialing agency or even to your quality assurance program. One of the initiatives of this report, thought through by a very distinguished committee, was to think clearly about a mandatory versus a voluntary reporting system. The committee defined errors as the failure to complete a planned action as intended or the use of a wrong plan to achieve an aim, and notes that not all errors result in harm. So many things happen that doesn't hurt anyone. But unless you identify those, divulge them, you won't correct the problems that led up to that error. And the next time it might harm someone. So the committee spent a long time discussing mandatory versus voluntary reporting. Congress immediately came out with a recommendation we should have mandatory reporting. We have that in the airline industry, we have it in the nuclear power, we have it in every other major high-risk industry. Why don't we have it in medicine? Number one, errors are very difficult to define in the complexity of the things we do. Number two, we've been brought up in this culture, physicians and healthcare providers have, that stresses perfectibility rather than the culture of safety. Number three, we worry about potential litigation claims. Are we going to be protected? In other words, is this information, if we divulge an error that didn't harm anyone, are we going to be protected from being sued? We don't know that. So as you might expect, the major medical organizations, such as the American Medical Association, came out very strongly against mandatory reporting laws. But I think that is one of the most controversial of the 4 steps that we will be hearing more about. And that will be part of this committee on the National Center for Patient Safety. One of their first tasks will probably be to determine how do we build a stronger voluntary reporting system. If we can't do that, how do we mandate it in a complex environment where errors are very difficult to even define a lot of times?
From my experience in hospitals, if a patient falls out of bed, that's an incident report, and it
Correct.
has to be done. It's mandatory. I'm sure that the nursing manager would be in big trouble if that were put down on paper and reviewed. So why is that a mandatory and no one complains about it, whereas other events might not be mandatory?
Yeah, that's a great question, because when we talked earlier about those systems in place, and some of those, like the adverse drug event report is mandatory, the incident report is mandatory, infusion policy diversion, in other words, when you're getting an IV fluid infusion in the hospital and you get too much or too little, that's a mandatory report, generates a mandatory report. And so there are certain segments of our healthcare system that are farther ahead. Those things are more easily defined. If I prescribe a medication to a patient for a condition that interacts with another medication that they are on that I didn't know about because they got that from a specialist or another consultant, and they have that interaction, that's a very we should be able to, we should know that. We should change our systems so that the primary care physician knows every medication or has some computer log of every medication the person's on. And so we should have systems in place so that doesn't keep happening. But is that reported as an error? No, it isn't.
Yeah,
it doesn't.
Okay.
Well, who does it even reported to? The physician is notified that, usually sometimes by a pharmacist, sometimes the patient, luckily, will be well read or will have a minor effect and will call and say, gee, I took your new medication and I got this symptom, and then the doctor tracks it and the doctor says what other medications you are on, finds out that they're on something that the doctor was unaware of and makes a correction. And everything's okay, minimal harm was done. On the other hand, next time, what about next time? It may be greater harm. So we have to get better information systems, and we have to define those errors.
Alan, we haven't had any calls, and we really would like to have some of our viewers phone in about this whole subject. And our number is shown on the screen, but it's 658-5165. And perhaps some of you haven't phoned in because we're talking in terms of agencies and regulations and bills in Congress or the equivalent within a hospital, new rubrics, new laws. But let's talk a little bit, Alan, now about how does the patient understand medical error in your practice, both as your own patients or in your work with residents, people learning how to practice medicine, and your work with nurses and other staff people. What would you say? How do the patients, who are, after all, the ones we're most concerned about, how do they respond when they hear there's an error, or do they know there's an error somewhere, or do they suspect it? You want to talk about that some?
There's a great variability, but there are some general principles, I think, that patients are generally common sense and common knowledge, but the relationship and the openness of communication that you have with your physician is of critical importance. That openness of communication and trust at times will lead the physician to say to you, I gave you the wrong dose of that medication. I'm glad you've picked up on it.
Instead of saying...
Instead of hiding.
Right. Hiding by saying, let's change to a different med. I think it might be better for you.
So
that's the historic way it's been done. The word error hasn't been used. Well, what's the advantage to use the word error?
Openness and honesty is critical in the relationship. Number two, the patient and consumer, and this has expanded tremendously in the last 5 to 10 years, needs to be well informed. They need to accept they need to know their medications or bring them with them to their doctor's office. When a plan of care is developed, they need to be perfectly comfortable with that. They need to be comfortable that their physician has consulted the right type of specialist or consultant when necessary. And this is an area where managed care has played a role in changing our behaviors a little bit, because everything goes through the primary care physician, and he or she is responsible for developing a plan of care and consultation. So openness, trust, being well informed, asking good questions, taking your questions in listed, knowing the doctor may or may not have enough time. If you feel that your provider, whether it be a physician or a physician assistant or nurse practitioner, has not had enough time to deal with all of your questions during that visit, set up another visit. Say, we didn't get all the work done we need to. Can we reschedule this in 2 weeks and go over it again?
Can the patient initiate that?
The patient should initiate that. And the physician should respond to that openly and appropriately. If the patient feels that they have been harmed, whether in some very bad outcome or even some minor outcome, tell the doctor, because the complexity of what we do now is such that the patient or consumer may just not know all of the issues that went into the decision to take this course. So if you are concerned, tell your physician that you're concerned. When we do our course for the medical students, we invite surgeons and educators and even a very prominent psychiatrist in to sit on a panel to talk about errors in medicine. And typically the surgeons who doing very complicated procedures have a great risk. You know, their technical skill is on the line almost every minute. And we will have surgeons that will come in and describe things that didn't go the way they had hoped in the operating room, that come out and make very honest and open discussions about those events with families and what they did to correct them. And that establishes a bond of openness and trust. And I feel better about that than a surgeon who is less likely to do that and more likely to hide. And so that's the culture that we're trying to change. So openness, trust, be well informed, ask your doctor, insist that your doctor takes the time around critical decisions, provide you with information or consultation when you think it's needed.
This is not a question of medical error, but I find it refreshing when I ask a difficult question of a physician and the physician says, I don't know the answer. I find that I don't find it discomforting. I find it helpful, that so I know where the physician's at. I know why we're puzzled, because there's no obvious way to move. So then I might say, well, then what do we need to do so you do have an answer, and then that opens the door for the physician to say, well, there are some other choices. I didn't know whether you'd be willing to look at them, and it furthers the conversation for the physician to admit they don't know the answer.
It's a very good point, because medical knowledge now is doubling every 5 to 7 years, which has led to a very prominent specialization of our care and subspecialization, because no one can know it all. And any doctor who presumes even the most sophisticated subspecialist to know it all is I think, kidding himself or herself. And that's, again, part of my initial interest in this was to look at how computer technology can relieve me of having all of that knowledge at hand and let me spend the most important time taking a good history, doing a good physical exam, and spending time with the patient on the decision analysis and choosing the right course, not necessarily having to link all of that with the most updated knowledge. So it's a complicated, and that's another issue around the comment that we keep making, how complex the environment is.
I'm concerned no one has phoned in. Haven't any of our viewers been to a hospital, seen a doctor, had a medical problem of some sort during their lives, or known someone close to them who have had medical problems? I know that everyone has had some experience with the world of medicine and healthcare, and it's inevitable. So I'm really want to encourage you to call in. This is an opportunity for you to talk frankly with our guest, Dr. Allan Ramsay, about medical error and the whole patient-physician relationship. You don't have to pay anything for this conversation. You don't have to even make an appointment. All you have to do is to pick up the telephone and call us, and we'll listen to what you have to say, even if it's unfavorable to doctors, even if you have nasty things to say. Our number is 658-5165. So please call us. We're only on the air until 12:30, so this is a special time for you to call us.
In our department at Fletcher Allen, we have begun, in our Quality Assurance Committee, we've begun a discussion around a voluntary reporting system for physicians to use the committee as a resource, because the committee has expertise to think through what were the system's problems, what were the things that led up to that error that can be prevented. The industries that do this best are those that look at each error as a gem, as a treasure. They get over the initial consequence, the initial feelings about it, and then they say, okay, we are never going to make that error again. How do we know we are still human? We'll make other ones, but we're not going to make that one. So we are looking in our Quality Assurance Committee at ways to allow physicians in the family practice program to make a voluntary report to the committee. And we've kind of set up different categories, and we're just at the kind of the forefront of that work, and I think you'll see, well, there will be more of that kind of local grassroots efforts as well. That plus the educational effort plus the openness that's going to have to come from this report. Physicians and medical systems in general, we're all trained in what we call the biomedical model. You learn basic fundamental physiology and anatomy of the body, and then disease processes, how they present, and then you apply those principles to choosing a course of action. That is the fundamental nature of our learning. Doctors are somewhat hesitant to use other systems, management systems primarily, which have been developed in other industries like airline or nuclear or weapons industries that probably would work very well in our culture. So there is some reluctance for the medical care systems to use things that are already done in our day-to-day work. But I think that will be an important step in the next few years too. And Congress and the Institute of Medicine will assure that those things happen. We tend to have a a culture of wanting to grow our own, wanted to produce our own ways of solving problems. But there are better systems out there.
When I go to see my physician or to have some sort of procedure done at the local medical center here at Fletcher Allen, I often get a form in the mail after my visit asking me to evaluate my experience. But as I remember, the evaluation is not really in terms of medical decision making. It's more the evaluation of was the examining room clean, were people courteous, was the technician on time, what kind of privacy did you have? They have those questions, but they're not asking, as I remember, we're not asking the kind of questions that might be helpful here.
Right. We again, you get those questions. You know, how was the parking? How long did you wait?
Yes.
Were people polite and courteous? We don't have ways of involving our patients in the decisions about what is good quality of care. We kind of define quality of care right now in an office setting as you didn't wait too long, your questions were answered, your checkout process was a smooth one, and rather than do you feel like the right things were done for you during that visit, and why do you feel yes or no? We just don't have good ways of integrating the patient into the quality assessment process. I think that as consumers become more sophisticated, they have much more access to information now through the internet, through television advertisements, direct-to-consumer advertising. As people become more sophisticated earlier in their lives and more knowledgeable about medical problems, they can participate in quality programs. They can make a better judgment. Did my doctor make the right choice for me based on my understanding of diabetes or blood pressure or gallbladder operation? And so I think that that is in the future as we get more access to information to more people. But you're right, right now satisfaction surveys are not quality surveys as much as they are, were you satisfied?
When you eat at a good restaurant, they often ask for comments, and sometimes if you feel very strongly, you can talk to the manager, and the manager will come and you'll explain that the wine is really kind of going into vinegar, and and they will well, let me get another bottle, and then he'll sniff it, yeah, or taste it, yes, I think you're right, or some delightful dessert that I've often had is kind of dried out and not very good, and they will say, well, we'll we obviously are not going to charge you for that dessert, and here, let me give you a voucher so that next time you come and eat, something's on us. Or, I mean, there are efforts at good restaurants to do that. We don't do that that I'm aware of in the medical world.
People are reluctant to make that kind of quick give that kind of quick feedback to their providers or to their clinics. They want to believe that everything that was done during that visit was the right thing, that they want to have a great deal of trust in their doctor, and by far and away, most of the times they're correct. And when there is a divergence, it's difficult for them to quickly assess that, because so many things went on, and give feedback. Though oftentimes in our clinics, we will get letters back from patients or phone calls about things that weren't discussed or were discussed, or discomforts or quality issues that we certainly respond to. But it is, for a lot of different reasons, difficult for a person to make those give that immediate feedback that you might give in a restaurant. There also is the fact that how things are compensated now is completely different. You go into a restaurant and you pay for your meal, and most medical care now is insured care. It's and
I'm on Medicare, and it's very hard for me to figure out what I'm ever going to pay or not have to pay. It's very complex.
So we are discussing, we're kind of getting to the end of our discussion about errors in medicine, and the number for our viewers is 658-5165. We have a few minutes to entertain any phone calls.
3 minutes.
So don't hesitate to call in over the next 2 to 3 minutes.
This is your last chance here, for the moment anyway, to talk with Dr. Ramsay about your medical experience, or medical experience of family or friends. We really would like to hear your frank response. It's hard for physicians to change some of the ways they've been functioning without input from our consumers, from the people we're trying to care for and to heal. So please call us, even for 2 minutes. It's worth your calling us.
And I will again summarize that that we are in a period of dramatic change in terms of the healthcare service industry, and that part of that change is breaking the silence that has surrounded medical errors and their consequence. That is going to lead to improved care, improved systems, more knowledgeable physicians, better consultations, better outcomes. So every one of our viewers, though reluctant to call so far, should rest assured that this is a debate that will bring added value and quality to every part of their medical care, and hopefully will also bring added trust and confidence and communication between them and their physicians. So I would certainly want to have everyone feel strongly about those.
Yes, please be honest and frank with your physician. Oh, we do. Welcome. We're glad you're calling. We have a minute and a half, maybe. Tell us who you are and what you'd like to speak about.
Well, who I am is not too important.
Could you give us a little more volume, please, Karen?
I'm getting an echo.
Is your TV on, maybe?
Yes. I'll shut it down. Put it on mute. Okay? Is that better?
That's better. Go ahead.
All right. The most important thing you need to know about who I am is the fact that I am almost 88 years old. So I've been seeing doctors for a long, long time. And I have had a real condition which I still feel has never been properly addressed. And that is perhaps fibromyalgia, but the result is pain. Pain, pain, pain. Years ago, I started telling doctors that my feet are dying, and nothing seems to be able to be done about it. And I'm still living with pain, which is very debilitating. I am very frank with my doctors. You don't have to encourage me to speak up, because I believe that it is teamwork. But still, I have not had the results that I look for.
May I interrupt you, and Dr. Ramsay, if you could make an answer, because we only have probably 30 seconds left.
The important thing is that you do have this relationship with your physicians and hopefully even a team of medical providers to help. Pain is a complicated area of medical care in which I agree with you. We have not done an adequate job of managing, and another whole initiative in terms of our national health care goals are to do better job at controlling the chronic pain syndrome that you're describing. And I would wish you good luck in that process.
I have one further comment. We're about out of time, but I wonder if there is a faraway consult somewhere where they would specialize in this lady's problem, where she might find some help.
It would be worth discussing with your physician.
Thank you for calling. We appreciate your speaking with us. It's been a pleasure to have you here, Dr. Ramsay, talking about medical error.